Clinical chemistry, porphyrins and myoglobin. Porphyrins, hemoglobin, and myoglobin all contain a porphyrin ring, and that's 4 pyrrole groups that are bonded by methane bridges. Porphyrin can chelate, or attach to metals, to form functional groups that participate in oxidative metabolism. Porphyrias are disorders associated with heme synthesis. Hemoglobinopathies are disorders of qualitative defects in the hemoglobin molecule. And thalassemias are disorders of quantitative defects in the production of normal hemoglobin molecules. The functions of heme-containing proteins are listed in the table below, so you can go ahead and pause the video and review these. Porphyrins are chemical intermediates in the synthesis of hemoglobin, myoglobin, and other respiratory pigments that are called cytochromes. Most porphyrins in the human body exist as porphrinogens, reduced compounds that are intermediates in the biosynthesis of heme, the non-protein iron-containing prosthetic group of hemoglobin. So hemoglobin, I'm sure you've heard of before, is a pretty large molecule. Hemoglobin has 4 subunits to it, and those subunits are called heme. So those are 4 globin proteins. In the center of each one of those globin proteins is a heme molecule. And at the center of each heme is going to be iron, and that's iron prosthetic group can transport oxygen. And we will learn a little bit more about the structure of hemoglobin next. This is just kind of touching base and giving a brief overview so you know where the heme is coming from. Porphyrins are photoactive due to extensive conjugation of the tetrapyrrole ring. They absorb light of 400 nanometers and emit a characteristic orange-red fluorescence between 600 and 650 nanometers. So this is what we can use to test for it in body fluids, and it's also explains some of the manifestations of the disease. So biochemistry, again, it's responsible for the synthesis of heme. All cells contain hemoproteins and can synthesize heme, but the majority of heme is synthesized in the bone marrow and liver. The rate of heme synthesis in the cells of the liver is achieved largely through the regulation of the enzyme ALA synthase. So an increase in heme causes a decrease in ALA synthase. A decrease in heme causes an increase in ALA synthase. The rate of heme synthesis is flexible and can change rapidly in response to many external stimuli. The pathophysiology is related to disorders of heme biosynthesis. Porphyrias are a group of rare inherited or acquired metabolic disorders that are caused by loss or gain of function mutations in the enzymes responsible for heme biosynthesis. Porphyrias can be grouped according to the clinical manifestations of the disease. So I'm going to let you read through these slides, but there is a neuropsychiatric version, a cutaneous version, and a neurocutaneous version. Secondary porphyrias are acquired conditions associated with increased excretion of urinary porphyrins. Liver disease and heavy metal poisoning can cause excess urinary porphyrin excretion in the absence of porphyria. So if you're having porphyrins seen in patient urine samples, it could be porphyria or it could be liver disease or heavy metal poisoning. Lead exhibits enzymatic formation of PPG, increasing concentrations of ALA, and coporphyrinogen oxidase function, which causes copro-3 to accumulate. Symptoms of lead intoxication are very similar to those found in acute porphyria. Testing for porphyrin disorders, you want to test for the precursor compounds PBG and ALA, and that utilizes ion exchange chromatography. Test for urinary PBG and ALA uses the Watson-Schwartz method. For dimethylaminobenzoaldehyde, or Ehrlich's reagent, it has an absorbance maximum at approximately 555 nanometers and a shoulder of 525 nanometers. Current assays allow quantitative measurements of analyte concentrations. Other tests for porphyrins enhance fluorescence of compounds in acidic solution, chromatic separation and quantitation with spectrophotometry or fluorometry, and molecular diagnostic techniques. Specimens must be protected from light. Porphyrins and their precursor compounds are stable in unpreserved urine at 4 degrees Celsius for up to 48 hours and can be frozen at -20 degrees Celsius for several weeks. Whole blood collection for protoporphyrin measurements should be anticoagulated with EDTA and stored in the dark at 4 degrees Celsius. So moving on to myoglobin. Myoglobin is found in skeletal and cardiac muscle. It contains one polypeptide chain and one heme group. Its job is to store oxygen in the muscles, and it will only release oxygen under low oxygen tension. So when oxygen is needed by those muscles, this is kind of the backup storage molecule for oxygen. The clinical significance of myoglobin, you can see elevated levels in serum and urine and in muscle damage cases. A combination of high serum myoglobin and low clearance rate indicates a high risk for acute renal failure. The primary use of serum myoglobin is the investigation of chest pain to rule out acute myocardial infarction. So when someone has a heart attack, their heart muscle gets damaged, and initially it will release myoglobin. You want to measure very early on from the onset of symptoms, so within the first 8 hours, and you want to measure a second time, again, a little bit later, but within the first 8 hours. And if you see a rapid increase in myoglobin, that's kind of an indicator, along with other signs, symptoms, and cardiac markers that we'll learn about later on in the semester, that can indicate a myocardial infarction. Myoglobin does not stay high in serum levels after a heart attack, so it will drop down back to normal levels after about 24 hours. So if a patient is being seen for mild heart attack or mild chest pain and they've had the symptoms for a period of time, myoglobin typically isn't one of the cardiac markers that's going to be investigated if it's been more than 24 hours. It's also been investigated to aid in the diagnosis and differentiation of types of hereditary progressive muscular dystrophy. There are several immunoassay methods that are used to measure and identify myoglobin: fluorescence, chemiluminescence, immunochromic. The procedures incorporate the binding of specific antibodies to myoglobin. Resulting chemical or physical change can be measured and correlated to myoglobin concentration. The methods have been adapted to point-of-care devices for rapid assessment of chest pain.